Hi, everyone. Thanks so much for joining. My name is Nicole Kuzmich, and I'm a healthcare data analyst for the Center for Improving Value in Healthcare, better known as CIVIC, based in Denver, Colorado. Today, I'll be presenting ED use for mental health and self-harm, what claims data is telling us about mental health care. First and foremost, I want to tell you a little bit about CIVIC and what we do. CIVIC is a nonprofit, nonpartisan, objective organization. As the designated administrator of the Colorado All-Payer Claims Database, or APCD, CIVIC oversees the collection of healthcare claims from Colorado's public and private healthcare insurers and uses that information to promote price transparency, inform policy, advance health equity, conduct research, and much more. Here's a brief overview of what's included in the Colorado APCD. Medical, pharmacy, and dental claims data from 2013 to 2022, totaling more than 1 billion claims, 40 commercial payers plus Medicare and Medicaid. Overall, we estimate that our database covers more than 70% of the covered lives in Colorado for medical claims. That's quite a bit of claims data that can be put to good use. Now that you've gotten more acquainted with CIVIC and who we are, I want to shift the topic to something that we can all agree is important: mental health. Mental illness can affect people of all ages. According to 2 reports published by the Substance Abuse and Mental Health Services Administration, or SAMHSA, and JAMA Pediatrics, respectively, 1 in 5 U.S. adults experience mental illness each year, and 1 in 6 U.S. youth aged 6 to 17 experience a mental health disorder each year. Those are some pretty severe statistics. What's worse is that many Americans living with mental illness don't always have access to comprehensive services or seek timely care to support their needs. In Colorado, efforts are being made to improve diagnosis and treatment of mental health conditions, reduce stigma related to seeking care, and expand coverage and access to services for those living with mental illness. Despite all of these efforts across the state and country, EDs, or emergency departments, remain a source of support for many suffering from potentially preventable mental health crises. Part of our mission at CIVIC is to support state legislators in their efforts to shape policy with timely data. This request came in from a state legislator wanting data on how the ED was being used to treat folks experiencing a mental health crisis. The data I'll be presenting today provides a snapshot of utilization, cost, and trends for visits to the ED with mental health or intentional self-harm as a primary diagnosis. In order to begin my analysis, I formulated a methodological plan. First, I scoped the project requirements to determine what filters or customizations needed to be utilized in order to narrow down the vast amount of Colorado APCD data to get my numerator. I landed on these key elements. The claim service dates that were included in this analysis range from January 1st, 2016 until December 31st, 2021. Both inpatient and outpatient facility claims with an emergency room flag indicator were included. Of those, only claims with a primary diagnosis of mental health or intentional self-harm were incorporated. Commercial, Medicaid, Medicare fee-for-service, and Medicare Advantage payer claims were included in this analysis as well. Lastly, I needed to determine my denominators for visualizing both percentage of total ED visits and rate per 100,000 calculations. Thus, the total number of ED visits between the years of 2016 and 2021 was used as the denominator for percentages, while the total number of covered Coloradans between the years of 2016 and 2021 was used as the denominator for rates. Claims excluded from this analysis were those with a total allowed amount less than $0, claims with reversals, capitated encounters, secondary payers, and professional claims. Total allowed amount represents the sum of the member liability, for example, copays, coinsurance, or deductible payments, plus the plan paid amount. Also, a couple of data limitations to keep in mind throughout. First and foremost, a quick reminder that this analysis only includes claims with a primary diagnosis of mental health or intentional self-harm. Secondary diagnoses were not included. Visit volume is calculated for distinct facility claims. Generally, there is only 1 facility claim per visit. However, it is possible that more than 1 facility claim occurred for a unique mental health visit on the same day. Although we won't review all of these in this presentation, the fields we reported on were volume, median cost, and total cost, percent of total ED visits, rate per 100,000 covered lives, top diagnoses for mental health and intentional self-harm, number of visits that resulted in hospital admission, and demographics-wise, we reported on race and ethnicity, sex, and age. Now, on to the actual data. Let's talk about some of my key findings from this analysis. First and foremost, let's take a look at the baseline data from 2016 to 2021. As you can see, the total number of ED visits with mental health or intentional self-harm as the primary diagnosis code continues to steadily rise year after year, while admissions rates generally stay the same, with a very slight downward trend. In 2021 alone, there were over 25,000 visits related to mental health and intentional self-harm, the highest amount of visits from 2016 to 2021, yet admissions rates are the lowest. Based on current trends, ED clinicians will continue to see increasing numbers of patients for mental health and intentional self-harm. According to an article published by Team Health, instead of providing expectant care while patients board in the ED, it's time for hospitals to take a more active approach to caring for these patients, moving with urgency to secure an evaluation, providing meaningful treatment and reevaluation with the goal of helping patients get better faster. This shift in thinking can help EDs deliver better care, improve the patient experience, and improve patient flow. Admissions data for mental health and intentional self-harm was also a topic of interest for this project. As you can see, in 2021, 8% of all mental health and self-harm ED visits resulted in a hospital admission. Cost data can be seen to the right, with approximately 46 million healthcare payments made for mental health and self-harm related ED visits, and about 20 million healthcare payments made for those same visits that resulted in a hospital admission. Now, just to clarify, healthcare payments means the sum of the member liability plus the plan paid amount. Member liability includes copays, coinsurance, or deductible payments. Now, let's take a look at the top or most utilized mental health diagnosis codes. Anxiety disorder, panic disorder, and major depressive disorder comprised 44% of all mental health-related diagnoses in 2021. According to a study done by Academic Emergency Medicine, anxiety and depression are growing concerns that are often difficult to treat and frequently exacerbated by perceived barriers to care. For example, lack of coverage, cost, difficulty scheduling appointments. These barriers can lead depressed and/or anxious individuals to utilize the emergency department for non-emergent concerns. Currently, most ED providers do not screen for mental health unless it is the chief complaint due to competing care priorities and limited resources. Another concerning finding was that there was a 158% uptick in youth ED utilization for mental health and intentional self-harm from 2016 to 2021. Not only that, but 20% of all mental health and intentional self-harm ED visits were youth in 2021. Like the youth population, Medicaid patients are also increasingly seeking out care for mental illness in the ED year after year. This chart, based on payer type, shows a 196% increase in Medicaid ED utilization for mental health and intentional self-harm from 2016 to 2021. That wraps up the most significant findings from this analysis. Overall, it's clear that this project had an impact, especially since it garnered a lot of public interest, including special coverage by local NBC affiliate 9 News here in Denver. Although this project was a success, there were still some challenges and subsequently lessons learned. Some of the challenges I faced were that the first iteration of this report did not include intentional self-harm diagnosis codes, so I had to use a combination of historical Colorado APCD data and reports and analyses in the wild to help me understand what results made sense. Additionally, due to data improvements being retroactively applied to historical Colorado APCD data, sometimes results differed from the first iteration of this report. This caused a need for collaboration with the data quality team, who was able to verify the accuracy of the data variances. And conversely, some of the lessons I learned were that defining a methodology, creating and gathering context for the analysis before even touching the data is of utmost importance. Having a structured plan makes pulling and analyzing the data that much more streamlined. I also learned that versatility is key. The willingness to change any aspect of a project multiple times so that it creates the most efficient use case possible is absolutely necessary. The data has to convey a message. A quick glance at my bibliography. And that's all, folks. If you have questions or feedback, please feel free to reach out to me at nkuzmich@civic.org. You can also stay connected with Civic on Facebook, LinkedIn, and Twitter, or by joining our email list at www.civic.org. Thanks so much for your time and interest, and I hope to hear from you soon.